Hello, everybody. My name is Melissa Leach, and I'm absolutely delighted to welcome you all to this public webinar for our project Pandemic Preparedness, Local and Global Concepts in Tackling Disease Threats in Africa. So why this? Why now? Well, I think in our world of intersecting global crises, preparing for future pandemics simply couldn't be more important. And this project, supported by a collaborative award from the Wellcome Trust, was conceived to bring a distinctive anthropological approach to this challenge, complementing biomedical and other perspectives. What we wanted to do was to explore relevant concepts, meanings, knowledge, actions in communities on the front line of potential outbreaks, which we term heuristically, though in absolutely no sense pejoratively, from below, and to look at how global, regional and national actors could better understand and support them. We began in 2019, and of course we soon found ourselves tracking an actual pandemic as COVID unfolded across our field sites and across the world. The project itself finishes early next year, and it's from the vantage point of the last few years that we now today want to share our findings and consider their implications for the future, and from the challenge that we've now come to understand as shifting power in pandemic preparedness and response. So the project has been quite a journey, and with an extraordinarily wonderful consortium, which has brought together anthropologists and social science researchers from Njala University in Sierra Leone, Gulu University in Uganda, in Senegal from the Centre Régional de Recherche et de Formation de la Prise en Charge de Cliniques de Fin, in France from IRD, and in the UK from the London School of Hygiene and Tropical Medicine, and from IDS, where we've provided overall leadership in the Secretariat. You're going to hear from and meet the entire team during this webinar, but I'm now going to hand over to my co-lead, Hayley McGregor, to talk more about the project. We have, though, got some important housekeeping points. One is that we will be recording this webinar for the future, so please be aware of that. We've also got interpretation to reach wider audiences in French and in Spanish, and a couple of our talks will be in French and in Spanish. That's available by clicking the interpretation button at the bottom of your screen. Simply choose the language you'd like to hear, and to hear the interpreted language only, click mute original audio. When the speakers are speaking in French and Spanish, and you want to hear it in English, just click English in the audio. And then finally, if you want to ask questions, and we'll have a lot of time for discussion, please use the Q&A button and keep the general chat box for other conversation. And we'll be dealing with Q&A at each point in the various sessions of the webinar. So Hayley, over to you.
So I'm going to give you a brief introduction to the Pandemic Preparedness Project. As Melissa has indicated, this is a project that had its aim from its inception to research the diverse concepts, meanings, and practices of pandemic preparedness. So at the outset, we were asking who is being prepared for what and by whom, and what can the world learn from people living with multiple health-related uncertainties in African settings? These questions had arisen from anthropological research by members of our team, particularly during the West African Ebola outbreak, and from other ethnographic fieldwork, which raised questions about the kinds of capacities, forms of authority, and social relations that people might draw upon when navigating intersecting challenges, such as disease outbreaks, but also extreme weather events, food insecurity, and so forth. In this regard, we were interested in exploring this idea of preparedness from below. In other words, the everyday practices of preparing and the local mobilization in response to such events. We also wanted to trace any connections or disconnections between local understandings and those in regional and global agencies. We thus also asked questions related to practical implications for preparedness, such as how global and regional efforts might interconnect more effectively with preparedness from below, and the kinds of capacities and global-local relations for strengthening inclusive preparedness. So to talk briefly about the themes and methods for the project, we were interested in how concepts of preparedness were configured in relation to three identified cross-cutting themes, namely risk and uncertainty, knowledge and information, and agency and authority, including formal and informal forms of authority. We selected sites in Uganda and Sierra Leone for fieldwork, with an emphasis, as Melissa said, on ethnographic insights from interviews and participant observation. In terms of the project, we started in 2019, as Melissa said, and inevitably with COVID-19, we shifted to a focus on preparedness and also response. Of course, the COVID-19 pandemic has catalyzed new thinking about the place of local capacities in preparing for and responding to disease threats. And we're now circling back in this webinar to reflect on preparedness and response and the future and the implications also for the future. Concepts such as community resilience and community-centered initiatives have entered the discourse of global institutions, alongside a recognition that preparedness for future epidemics will need to address longer-term systemic concerns. Yet whilst there's much emphasis currently on improved surveillance and technical advances, such as vaccine platforms for immediate readiness, we think there's still less attention to identifying and understanding what we've called preparedness from below, seeing this as a complementary effort to these conventional preparedness investments. So this leads me to focus on the themes of the webinar today, and a word first about the title of the webinar and our aim to foreground shifting power in pandemics. Here we want to link to discussions in decolonizing global health that point to a need for avoidance of inadvertent entrenchment of established power hierarchies, and to ensure that better connections across scales of response can support inclusive and acceptable actions. And by invoking the phrase from below, we're very much wishing to explicitly challenge these entrenched inequalities and also assumptions about whose knowledge and experience counts in shaping policy. And as you will hear as we present the findings in this webinar, our ethnographic work has really revealed the experience of COVID-19 in different African settings and provided a picture over this period of shifting understandings of the pandemic. People living in the field sites profess to not seeing much COVID-19, especially initially, but the pandemic has had significant economic impacts for them, including impacts as a result of the lockdown measures that were implemented in very stringent forms, especially in Uganda, where we will talk a bit about the militarization of the response. The fieldwork led us indeed to advance our concept of preparedness from below, to include the idea of intersecting crises that people face, including these effects of epidemic control measures themselves. And we suggest that people do not just accept, but actively negotiate these intersecting challenges as they seek to sustain their livelihoods, including through mutuality and collective action. And having the pre-existing capabilities and forms of collective organization in dealing with everyday uncertainties, we will argue, is key to preparedness from below. Our research has also foregrounded concern with the COVID pandemic's intensification of pre-existing challenges of life, and it really underscores the importance of expanding formal understandings of preparedness to include attention to systemic conditions that influence the effectiveness of response. And I thus also want to just comment on the image that we've used to promote this event, which you would have seen. And this is a photograph of a person in a village in Sierra Leone during the West African Ebola outbreak, wearing homemade PPE and personal protective equipment that had been constructed in the community. And whilst this could be read as an indication of self-reliance in response to the epidemic through improvisation, we also want to examine the idea of community resilience in a critical light and avoid any romanticization of this level of response, emphasizing that people in local communities also require access to the staff, space and systems that Paul Farmer so pertinently highlighted as the necessary substrate for effective control. So For our webinar, we have our first session, which will build on and engage critically with discussions of community resilience and community-centered response. Then in our second session, we will be focusing on deepening understandings of how diverse publics engage, particularly with so-called technical interventions such as vaccines, and also focus on the need to address longer-term systemic concerns such as those related to health systems and political economic conditions. And then finally, in our panel session, session 3, we'll discuss implications for new approaches to preparedness. So finally, from me, just to give you an idea of the timing and structure. So we'll start with session 1, which will be chaired by our project co-investigator, Professor Melissa Parker. This will focus on learning from and with communities, with a selection also of discussants, which we will introduce in due course. In session 2, we'll focus on technologies and systems, and this will be chaired by our project co-investigator, Professor Alice Desclos. And then our final panel session will be chaired by our project principal investigator and director of IDS, Professor Melissa Leach. So now let's get started, and we will introduce the first session, and I will hand over to the chair, Melissa Parker. Melissa is a professor of medical anthropology at the London School of Hygiene and Tropical Medicine. Over to you, Melissa.
Thanks so much, Hayley. As already indicated, researchers on PPP have carried out long-term ethnographic fieldwork at different scales over several years. In Uganda, some of this research focused on Pakwach district in northwestern Uganda and a village in Kasese district in western Uganda. Both field sites lie close to the border of DRC. Additional fieldwork was carried out in parts of urban and peri-urban Gulu, a city in northern Uganda. In Sierra Leone, research took place in predominantly rural settings in Kailan district, Eastern Province, and Moyamba district in Southern Province. The researchers leading the fieldwork in Uganda and Sierra Leone have all made short 3 to 5 minute videos. As you will shortly see, they've chosen to foreground a diverse range of topics. So in Uganda, this includes the enforcement of lockdowns by the Ugandan Armed Forces, the way in which new modes of mutuality emerged to resist or subvert the regulations being enforced, the role of the armed forces in rolling out COVID-19 vaccine programs, and experiences of home-based care. In Sierra Leone, the videos foreground the way in which the 2014-2015 Ebola outbreak profoundly influenced early responses to the unfolding COVID pandemic. The impacts of lockdown on food security and changing understandings of the COVID-19 vaccine program are also foregrounded. Now, it goes without saying that these videos provide only a snapshot of a complex array of issues which unfolded over a considerable period of time. So while recognizing the specificities of the issues being foregrounded, there are also some very clear themes which link these presentations, both within the two countries and also across study sites. So just to give a few very quick examples, the lives of many of the people that contributed to the research are by any definition precarious. In all cases, COVID-19 was just one of a multiplicity of hazards and challenges that they faced. Obviously, the specific hazards varied from place to place, but included outbreaks of infectious diseases such as malaria, cholera, typhoid, and Ebola, but also seasonal flooding, food insecurity, forced displacement from political instability. It's impossible to accurately capture how and why people responded to an outbreak such as COVID in the ways that they did without recognizing these intersecting precarities. To this end, we have, as Hayley indicated, given some thought to developing this concept. And a further theme also, which Hayley has touched on, which emerged in research carried out in Uganda, but interestingly was much less evident in Sierra Leone, was the role of the armed forces in epidemic preparedness and response. Here, the focus on formal and informal public authorities has been particularly helpful, as it's helped to foreground the socio-political dynamics on the ground that would otherwise remain obscure. Such a focus has proved helpful to understanding how and why villagers and urban dwellers have found often novel ways to mitigate the social and economic impacts of stringent public health measures. Now, for many people on this call, it goes without saying that it's hugely helpful to engage with the granular details emerging from these diverse field sites, while continuing to think in a comparative way. So hopefully one of the outcomes of this webinar would be to just think a little bit more deeply about all these taken for granted concepts, be it resilience, health security, care, and ultimately to refine our public policies as a result. So I'd like to extend huge thanks to our Ugandan and Sierra Leonean colleagues who've taken the time to make these videos. Their names are listed on this slide. Bob Okello, Moses Baluku, Peter Kamundu, and Bono Azunga have all done fabulous fieldwork in Uganda. So too have Marian Nyakoi and Fode Kamara in Sierra Leone. So we shall start these videos with, I think it is, Bob Okello talking about home-based care in Uganda. Thank you.
I'm Bob Okello. I've been working on home-based care in Gulu and Kasese district. The World Health Organization have clear guidelines about how to implement home-based care for COVID for those who are mild and moderately ill with COVID. These guidelines were adjusted by the Ugandan Ministry of Health, and the policy was rolled out in June 2021. In Gulu and Kasese district, this happened in the context where caring for the sick people within the home is our usual practice. Home-based care for us takes place in a moral space. It creates and sustains social connection between people who are deeply about each other, who deeply care about each other. Global and national ideas about home-based care are different. They are bringing clinical care into the homes, and it does not work well. That is the idea that people are thinking. At times, it feels like an attempt to colonize our ideas of care. While some would argue that this is a good thing, I think we need to be clear about what is imposed and what these impacts might be in terms of both social and economic. As it stands, home-based care for COVID, as implemented, has been flawed, and it only works well for a small number of people.
I have been working in the village in Kasese district on the border of the Democratic Republic of Congo since 2019. During the Ebola outbreaks in the DRC in 2017 to 2020, there was a permanent military base at the edge of our village. So when COVID-19 unfolded, villagers initially perceived the involvement of the military as legitimate. While restrictions lifted in other parts of Uganda, a partial lockdown continues in our village. The military presence is no longer perceived as legitimate. It is creating a lot of difficulties for us, including having to move at night to the military stationed at the DRC border. This can be dangerous, but they have no choice, as it is the only way to access the crops that they are growing on land that they own or rent in the DRC. My people are also having to pay bribes to the Ugandan military as well as the Congolese militia, not only to access our land in the DRC, but also to carry on trading cattle and other items across the border. The impacts on health and healthcare are also considerable, and our village healthy team workers feel undermined by the presence of the military. They ask, why are the armed forces so involved in rolling out the COVID vaccines? Why are they not helping us to take responsibility? What is the purpose of this vaccine? With the breakdown in trust, women are less willing to take their children for routine vaccinations. All this is happening at a time when there is a regular influx of Congolese refugees, seasonal, but significant flooding and food security. Thank you.
I am Kelmondo Peter, a PPP research officer. I work in the sub-county, in Pakwach district, a bordering point between Uganda and the Democratic Republic of Congo. I have been researching on COVID-19 vaccine enforcement among the local people. Official statistics suggest that they have the highest vaccine coverage rate in the whole of Uganda. The military were closely involved in the providing vaccines, and their involvement caused a lot of fear and anxiety among my people. For example, there was a lot of beating and caning of people who refused the vaccine. In some cases, they beat them until they accepted to have it. In other cases, young women were so fearful of how the vaccine might affect their fertility that they pretended to fall in love with army commanders in the hope that they would be able to help them avoid the vaccine. It would have been better if they had talked to people in a soft way. This would have enabled army officers not to be perceived as the enemy of local people. Thank you.
My name is Bruno Ozonga, a researcher with PPP. I've been looking at the social impacts of militarized response to COVID-19 among people living in villages and small towns in the Pakwach district on the border of the Democratic Republic of Congo. Whereas Uganda has an ideal public health governance framework running from central government to local governments, the Ugandan Army overran and sidelined the decision-making of these structures, with border areas, including mine, receiving heavy deployment. The armed forces were a feared presence, shooting live rounds of ammunition into the famous fish market in the area, so that people were dispersed. The army continued to behave violently throughout the lockdown. For example, the pastor was beaten until he was unconscious, even though he was a few meters away from his home. The Boda rider was also beaten thoroughly, even though he had official approval to travel from the arrested district commissioner, the issuing authority that time. A prominent businessman was severely beaten until he was unconscious for moving at night. A parent was beaten as he sought emergency treatment for his anemic child. Fishermen were also targeted when they came back to landing sites with fish. With no support forthcoming, people had no choice but to break some lockdown restrictions to survive. For example, Boda riders moved at night through bad and unfamiliar routes to evade roadblocks. People at the border used ungazetted border points. Businessmen hid tradable items in food sacks for purposes of evading security checks. Saloon owners locked themselves inside their shop as they served their customers. Bar owners locked themselves in their room while they drank. Fishermen moved at night with their fish, and so forth and so on. Now, my question to the panel is, with the rise of authoritarian governance. I am keen to learn from colleagues what all this might mean for enabling meaningful community engagement and resilience. Thank you.
I am Mariam Bibimenya Kwai from Sierra Leone. I have been working as a field worker with the Pandemic Preparedness Project, PPP, since the time of the COVID-19 outbreak in 2020. My research was undertaken in Shawi Chiefdom, Kailan District. It was one of the first and worst affected communities during the 2014-2015 Ebola outbreak in Sierra Leone, when a nurse infected was brought home for burial. For that reason, it was an interesting place to observe the impact of the COVID-19 pandemic in 2020. Community leaders in Jawi Chiefdom were especially alert to make sure that their people abided by the national and local rules and regulations for control of COVID-19. This included the rapidly revived local bylaws whereby no strangers were allowed into the community. Even village resident people coming in from other towns or communities first had to go to the local village clinic to be screened by the nurses or community health workers. Lockdown was something that affected the people in their communities, especially pregnant and lactating mothers, as it threatened the food supply and caused inadequate food intake. Military forces regularly visited this section of the chiefdom to inspect whether lockdown was being obeyed. They were thinking that failure to obey the rules would result in the same high death toll of their people experienced during the time of Ebola. The impact of lockdowns on food supplies was significant as women experienced difficulties in obtaining food for the house for days on end. Most fed their children with whatever they could find, and some of these foods were unhealthy. For example, sieve rice blended with a pinch of salt and a few drops of palm oil. Some use rice porridge alone. Those who risk evading lockdown went to their farms to dig some bushams, cassava, etc. for family consumption. Others whose husbands were motorbike taxi riders were occasionally able to find some basic needs if and when shopkeepers had stock and were willing to sell items on the quiet. This was a famine caused by COVID regulations. Unfortunately, the government realized after a few weeks that it was dangerous and could not be sustained. The biggest problem caused by COVID-19 at the onset was overreaction based on an initial belief that the pandemic would be worse than Ebola. To conclude, Sierra Leone has to develop its own response and not to follow international advice alone. I thank you all.
I'm a research officer working with the Pandemic Preparedness Project. I had carried out participant observation studies. I made general inquiries and observations concerning the ideas of the people on pandemic preparedness for several months before the pandemic of COVID-19 struck. I was then in place to witness how people then cope with this new threat to their health, livelihoods, and the ways in which their responses changed, both in the face of the epidemic itself when the pandemic arrived in April 2020. One of the topics I studied before COVID-19 arrived was the way in which the chiefdom authorities mobilized the community to resist Ebola virus disease in 2014-2015. This was by means of a chiefdom Ebola Task Force Committee, which imposed nationally mandated bylaws on Ebola control. As a result of strict restriction on local movement, the chiefdom maintained a zero case rate for Ebola infection throughout the 2014-15 outbreak. However, the outbreak of COVID-19 in 2020 changed our research focus from preparedness to response. Initially, there was a widespread understanding that the Ebola response, based on bylaws and quarantine, will also protect against COVID-19. Markets and places of work were closed, and social distancing and mask wearing were imposed. Unlike Ebola, the symptoms of COVID-19 were much harder to detect and less dramatic. It was a disease affecting mainly old people, and I undertook household censuses, showing that the elderly were only a small proportion of the total population. Also, the disease spread in a different way on the air and not through contact with body fluid, so it was much harder to control than Ebola. There were two problems. Therefore, people could not see the disease, and the benefits of strictly imposed quarantine were much less obvious, since there were very few, if any, serious cases. I also followed up on various other topics. One was the impact of market lockdowns, which were very severe and responsible for food insecurity. Another was mask wearing, which people saw as being beneficial in protecting others, themselves, and bike riders against dust. Later, vaccine arrived, and I spent time following up with informants their changing ideas about vaccines. Initial resistance was linked to misinformation. I followed one chief who had earlier told me he would never take the vaccine. Later, I found that he had changed his mind. He explained that bylaws were the best protection from disease as under Ebola, but that if he did not take the vaccine, others will not accept the bylaws. In conclusion, pandemics are moving events, and participant observation is needed to monitor often rapidly changing attitudes, understandings, and response. I thank you all.
Thank you very much to our researchers for those wonderful presentations. It's now my pleasure to introduce our 4 discussants for this session. The discussants will be offering short 3 to 5 minute remarks in response to the project findings that we presented. So we have Dr. Guillermo Sequeira, head of the National Health Surveillance Directorate of the Ministry of Health in Paraguay, and he'll be speaking in Spanish, so use your translation button. We then also have Dr. Amoni Jackson, who's a public health physician from Uganda. We have Dr. Alfred Jamiru, who's Vice President and Corporate Secretary of the Amaloma Development Foundation, and also has held various positions in Sierra Leonean government related to emergency response. And then finally, we also have Dr. João Rangelda Almeida, Technical Officer at the World Health Organization in the new Readiness and Resilience Unit. Before we hear from our discussants, I would just like to remind the audience that you can please post your questions by using the Q&A button, and we'll have a period of discussion after we've heard from our 4 speakers. Do go ahead, Dr. Sequeira.
Hola, Melissa. Hola, Mrs. Halley. ¿Me escuchan bien, no? Ok. Bueno, gracias por la oportunidad de conocer esta experiencia. Me parece fabulosa esta construcción de una respuesta o de una preparación desde abajo. Me parece una idea muy potente, muy útil, más allá de las pandemias o eventos catastróficos como puede ser el ébola en África. Nosotros en Paraguay tenemos epidemias recurrentes como es el dengue, como es chikungunya, que tenemos todos los años, pero que algún que otro año, cada 3 o 4, es muy importante. Y bueno, la construcción de la resiliencia en esa comunidad que vive esa enfermedad cada tanto, que conoce cómo abordarla, más allá de los conocimientos médicos, hegemónicos, occidentales, la construcción de la resiliencia de la comunidad es importante. Una cosa que quiero agregar y que lo viví un poco trabajando en el Ministerio de Salud cuando fue todo esto de la pandemia del COVID, es un poco entender que la pandemia también tiene sus momentos para la comunidad, ¿no? O sea, uno se prepara para ese momento duro, para ese momento donde hay miedo, donde las directrices verticales, ya sean militares, ¿no? Como comentaban los de Uganda, en nuestro país pasó algo similar, o de los médicos, ¿no? La cultura médica es muy vertical también, y en nuestro país lo que dice el médico es casi hegemónico y es vertical y es casi de Dios, ¿no? Un estatus prácticamente social diferente, con un mandato de disciplina, prácticamente no discute con la comunidad. Bueno, eso lo vivimos en Paraguay, pero hay que entender que la pandemia tiene sus etapas desde lo social, ¿no? Que está el momento del miedo, está el momento también de ir perdiendo en el miedo, está el momento del cansancio de la comunidad a esa situación, y de desafiar también a esa situación como comunidad, ¿no? Yo creo que hay que prepararse también para cada uno de esos momentos, ¿no? No solamente para el momento, el shock, ¿no? Creo que hay que tener una lectura de que todos esos tiempos ocurren y hay que prepararse para esos momentos, ¿no? Prepararse para la pandemia, ¿no? Es un esfuerzo colectivo, no es un esfuerzo individual, es un esfuerzo colectivo. Y allí yo quiero destacar en mi país, y creo que algo lo comentaban en la experiencia de Sierra Leona, y en Paraguay, yo creo que en la cultura latinoamericana es muy fuerte el rol de cuidado que tienen las mujeres, ¿no? El rol de género femenino que está muy relacionado al cuidado en países que tienen malos sistemas de protección social. eh, em, Allí es donde la cultura colectiva y el rol que tiene la mujer del cuidado, como casi un sistema de salud tácito, ¿no? Es la madre la que lleva a vacunar a los hijos, la que lleva a su marido a vacunar, bueno, la que da las recomendaciones de qué es lo bueno para la comunidad, son las mujeres. Entonces, creo que eso en Paraguay fue y es muy importante negociar con eso, entender eso, trabajar desde ahí, empoderar a la mujer en esa cultura del cuidado, darle herramientas, y eso se multiplica en la comunidad, ¿no? En Paraguay fue muy interesante cómo en los momentos donde sí fue duro conseguir alimentos también en las cuarentenas, no tanto por presencia de militares y esto, sino porque no había movimiento de materias primas, porque había lugares inaccesibles. Entonces, era esa red de mujeres, o sea, una red de mujeres, de madres, de las mujeres, de las líderes del barrio, que tienen una lectura de eso, del cuidado, del alimento. Se hacían lo que llamábamos ollas populares, ¿no? Mesas comunitarias donde las mujeres cada una traía a lo que tenía y se hacían estas ollas populares donde comía el barrio. Luego el gobierno tuvo una lectura positiva de eso y potenció eso, ¿no? Yo creo que eso es algo interesante, tener la capacidad de leer esas potencialidades que tienen las comunidades y darle fuerza y fortalecerlas, ¿no? Eh, eh, Entender esos códigos, esas redes, yo creo que y este trabajo que están haciendo ustedes me parece fascinante, poder darle valor, darle un marco teórico y hacer más fácil para que los gobiernos o los hombres que generalmente están en los cargos, ¿no? Vean vean esa potencialidad que tiene la comunidad, y que es muy útil. Creo que más allá, la comunicación de riesgo, creo que se cuestionó mucho en todos los países. En Paraguay y la comunicación fue mala, pero creo que fue un problema global de esto. Pero yo creo que también una pregunta interesante, una comunicación de riesgo al revés, es cómo hacer que los científicos o que el sistema de salud nos escuche, nos entienda. Creo que por ahí está un poco este paso que están dando ustedes y me parece fascinante, ¿eh? Bueno, me quedo para seguir discutiendo.
Thank you so much, Dr. Sequeira. That's a really interesting snapshot from Paraguay, and we'll continue the discussion. So if I could now ask Dr. Amoni Jackson from Uganda, if you could offer your short remarks, please.
Yeah, thank you so much. I want to thank you for giving me the opportunity to communicate what happens in Uganda. Right now, as I talk, I'm in the field responding to the Ebola task force which about the Ebola epidemic. Let me just remove my mask because I was in the field. I'm the case management coordinator for the Ebola task force in Uganda currently. And what we always do in Uganda is that we really cherish the involvement of the communities. And I want to thank the study which was really done to ensure that we involve the communities. Usually what we talk about is that epidemic starts in the community and it ends also in the communities. So the involvement of the communities are really important. So we need really to involve the community right from the start. In Uganda, usually when there's an epidemic, we have pillars which we commonly use to ensure that we respond to the epidemic promptly and within the area where the epidemic is. Currently, we have about 8 pillars which we are using, especially for the Ebola epidemic, which is in the country. The first one is the coordination, which looks at the finance and then how to bring the partners in line. The second one is the surveillance and epidemiology. The third is case management. The fourth is risk communication and community and involvement. The fifth is the logistics. The sixth is the IPC. The seventh is looking at the public relations. And then the fifth, the eighth, I'm forgetting. But each of these pillars, they have their responsibilities that they do, especially the risk communication and community engagement is so important that once we have them on the ground, they tell us what the community thinks. Sometimes the community don't want to report to our health facilities, but we ask the anthropologists working together with the risk communication, what is the problem? And this really inform the response, what we should really be doing. And sometimes people fear our isolation unit because they think when you get into the isolation unit, that's the end of you. So we make a lot of communication. We do a lot of teaching. And it is through this teaching that we can also do some training. We train people in the community. And once you train the people within the community, either as responders or people who are going to take the message home, that brings the community closer to the responders. Sometimes we have got some survivors, which when they come out of the treatment unit, they are like our mouthpiece. When they go to the community, now they begin telling the community what really happens. And sometimes they allay the fears, what many of the people in the communities are doing. But it is not very easy sometimes to enter into some communities because different peoples have different cultures. Some culture, they really honor the dead body so much. Some culture, when they're going to bury, they don't want other people to attend. And like us, for now that we are responding to the Ebola epidemic, all burials in the community, all burials from the health facilities are supposed to be conducted by the safe and dignified burial teams. So what we are doing is we have to emphasize that the community should really work with us. The community is a pillar. It's the community are the people who can lead where there are problems in any of the response. So when we think about beginning the planning for a response from below upwards is really important, because even when there is some suspect, when there is some issue that there may be an epidemic in a place, it is the community people who can blow the first whistle that you see in our place, maybe we are having a lot of deaths, people are falling sick, so many, what is wrong? And they can report to the health leadership, and health leadership can come and really respond very fast. And that may not be easily available to the surveillance team. And when they blow that whistle, that's when the surveillance team, be it an active or a passive one, can be put in place to ensure that the response can begin. The rapid response team can now go and investigate to see what is really happening, and then they inform the Ministry of Health on what should really be done. But otherwise, I'm not saying that the other pillars are not important. The other pillars are also important, but the responsibility of the risk communication and community engagement is really paramount in managing an epidemic that can occur in any country. Thank you so much. This is what I want to add to what has been discussed. Thank you.
Thank you very much, Dr. Jackson, and for giving us that sort of real-time picture indeed of the latest epidemic challenges in Uganda right in the field. And thank you also for foregrounding that centrality of working with and engaging with communities in that work. Dr. Jamira from Sierra Leone, I wonder if you would follow and comment also on the project findings regarding Sierra Leone. Thank you, Dr. Jamira. Dr. Jamiru, do you want to unmute yourself and offer your comments?
Can you hear me?
Yes, we can. Go ahead.
Yes, yes. How is everybody doing today? One of the things that I just want to really speak to, and it's just basically to what have been presented and my experience working with the coronavirus in Sierra Leone. One of my concerns that I have is that we interject words into our overall work activity, otherwise, in my opinion, which has already been used. So, for example, today we are using working from below, which I am understanding to mean that one, the top-bottom approach, and two, the community-led approach. So we also want to be clear that when we make some of these interjections, especially with words like working from below, I'm hoping that we give clarity so that people know that it is either the same or there is a difference. I also share all of the concerns that our various panelists presented, these especially experiences with military officers in the midst of all of the situation. I was responsible for social mobilization in Sierra Leone. And one of the concerns that I also had raised, even in our intra-action review at WHO, is the way we understand social mobilization and community engagement, which I always try to separate to mean that social mobilization is the bigger picture of getting everybody be aware of what is going on. Our community engagement is now the focus, because let us don't forget, when pandemic happens, pandemics do not happen in all of the communities. So even in our interventions, there is a focus. The focus to those communities where the pandemic is slightly different from where there are no pandemics. So I just wanted to say, based upon what I've heard today, a lot of efforts have been made have been put into this. But what I'm particularly happy about is that they said power to the people. I am understanding this particular action as power to the people, which means that at the end of the day, I mean, it's not like the policy makers, the scientists, the health workers, the decision makers know it all. We are now saying, and I proudly want to be part of this, we are now saying, give the responses in pandemics, give the power to the people. Let the people also chart their way forward. You provide the guide, because at the end of the day, you know how the disease is working, how it should be done. But when it comes to working with the grassroots people, let them take leadership for themselves. Because at the end of the day, like one of the speakers said, it starts with the community and it ends with the community. Thank you very much.
Thank you, Dr. Jamira. Very powerful set of comments there. Finally, I want to invite João Rangal de Almeida from the WHO to offer your remarks.
Thank you, Hayley. Thank you. And thank you for the videos. I think there are a few issues that come out of the videos that are really important to reflect as we think about health emergencies across the cycle, from preparedness to readiness to response. And the first thing is the dynamic social licensing that communities provide and keeps changing, right? We heard from speakers that initially the military was accepted and was trusted, and that licensing changed. So understanding that dynamic dimension of licensing seems to be really important. The other thing is the fact that these communities and individuals are rational agents, and they, as rational agents, they need to measure and make really tough decisions. We heard about the decision between quarantine or having access to crops, or quarantine or being able to mobilize fish to markets and provide for their families, and thinking about the social context, economic context of these outbreaks is fundamental. So mechanisms of community protection can be embedded in the response. I think the third thing is that epidemics do not happen in a vacuum. They exist, they happen in existing social structures. So we heard about the military in Uganda, and that is not an abnormality. It's a fact that the military is ubiquitous in that society. Think about the response in Portugal. Also, the military was involved. So each country, each social structure has its mechanisms of addressing issues. And it's very difficult in the heat of a situation to think about changing those. So we need to think about how do we work with these existing systems so we can adapt and localize them. And finally, issues of accountability. And that accountability goes at all levels, from global to sub-regional, right? Accountability of my neighbors, accountability of my leaders, political, religious, accountability of structures like the World Health Organization, World Bank, and so on. All this to say that the process of managing health emergencies is very dynamic, and we do need to understand context, and we need to bring data and evidence into our responses. And this is not evidence and data just for the sake of data, but with a very particular operational need. How can we adapt our operations to what the social dynamic systems are, how they are responding to these challenges? Thank you.
Thank you very much, João, and particularly relevant because of the work your unit is doing on community resilience. And thank you for reminding us about preparedness, dynamic, social and political process. We're now going to move to a period of Q&A. We have 15 minutes for that. Please do add comment and questions in the chat. And the Q&A, sorry. Melissa, do you want to start us off with?
Yeah, there are questions coming in thick and fast, but please do keep adding them in, and Hayley and I will do our best to kind of try and get them all addressed. Just to kick off, obviously, sort of recent comments on the role of the military in outbreaks. I wonder if we could, one colleague, Paul Richards, put in the chat that the presentations didn't foreground the perspectives of the armed forces themselves in terms of how they understood what they were doing, which is correct. But I wonder if we could hear perhaps from Grace and also from Fode. So for Grace, perhaps you could comment on the perspectives of the armed forces in the during the COVID-19 outbreak. And from Fode, I don't know if you would like to say something, comment a little bit about why the military were less involved in Sierra Leone during the COVID outbreak compared to the Ebola outbreak, and what lessons might have been learned from the military engagement during the Ebola outbreak that carried forward and shaped their relative lack of action in the early days of the COVID outbreak. Grace.
So thank you, Melissa. I did various interviews with the military, but I approached them as members in the surveillance team. For instance, as soon as the first lockdown was eased in May 2020, the key personnel or the key persons who were still active in containment, in disease containment, were the military. And so their tasks were varied, for instance, to ensure enforcement of SOPs. By the third month, many people in my country were really exhausted with these SOPs, social distance, wearing masks, washing hands and using sanitizers. And some places actually they did not even have sanitizers or even water for washing hands. And so it is in this context that the military upped their game, if I call it this. So in my country now, if there are things to do, like there are responses to emergencies, first the state will deploy the policemen. The policemen are more trained to deal with civilians and also to deal with these contradictions. For instance, you tell somebody to do something and he can talk back, okay? Like, why are you not wearing a mask? To a policeman, a civilian can say, okay, I cannot afford it, I forgot it, and so. But the military are more interested in obeying orders. It's about how high should I jump, yeah? So this big difference here makes it very difficult if the military are deployed for a task compared to if the police is deployed for a task. On a few occasions, the president ordered the military, especially in the Kampala area, to help in surveillance. Because, for instance, the president can give a speech and say, stay at home, yeah? But people like live hand to mouth. They have to work, they have to earn a living, or they have to access some basics. So for a policeman, the civilian can talk to them like, okay, I have to go to shop, I have to see a sick person in hospital. But for the military, the difference is that they want to obey the orders to the last bit. Like if the president has said, stay at home, anybody who is found on the street has no chance or is given little opportunity to explain themselves. So after the president realized this, there were less and less deployments of the military for pandemic preparedness and pandemic response. And I think what Moses says is that the military is still present in DRC border because of the militia in DRC. They are not there particularly for disease response. And if we can discuss later, or if we can talk to them really about the tasks or the different activities they are supposed to undertake, it will be mostly to monitor the security, the fragile security situation there. Okay, and of course.
Okay, great. So I'm going to stop you there so that others also can ask their questions.
Thank you.
Fode, would you like to come in and make a comment? You don't have to.
Yeah. Let me come in. Hello.
Hi, we can hear you.
Yeah. So let me just say briefly on this area of the military and controlling pandemic. You know, initially when the Ebola outbreak was within the country, there was a lot of misinformation. You know, we are seeing a lot about the military and so forth. So I even follow up with some other people at that time when the Ebola was very serious. You know, whenever the barrier teams were appointed to be taking charge of barriers, because World Vision and the government instituted what they call dignified barriers. So people we are appointed that we are trained that undertook those dignified barriers. So whenever somebody dies, the team there will go and collect that dead person and take it to the cemetery for burials. So there was a lot of story, there was a lot of talks about that. You see, the people, when the people go for these people, they just spray their chlorine, they are killing their people. So there was a lot of story about the burial team. So you see, so this misinformation was a problem in the fight of this of Ebola. So when COVID also struck, there was the same misinformation that was going on. Some people say, I don't believe, I don't trust what is going on. They are just lying, just some Western talk that they want to reduce the African population. I got a lot of tales from my informant in my community about this fake talk about the COVID. So for the government to really have some stance in fighting this COVID, they decided to use the military. Using the military that can create some fears in the Africans, because we Africans, we fear the military because they have guns. So when they say don't do this, whenever the police say don't do this, they don't even have time to abide by those commands by the police. But not so that they say the military, that will put some effort in them to fear. So the military were stationed all the other checkpoints. Most of the officials that were working with the message of COVID, they were having the military to just make sure that people abide. People make sure that they abide by the wearing of masks, the laws that are put, they make sure that they follow all these laws. That's why the military were very, very important in the fight of COVID. And indeed, we saw what happened. We are able to at least bulldoze the pandemic. Thank you very much.
Okay, thank you, Fode. I think we probably got time for one more question. A very interesting question which has popped up, which is, I was really struck by how Bob Okello described attempts to improve home-based care as ending up, in effect, attempting to colonize people's ideas of care. The question is, how might we better reconcile local notions of care with global understandings of an epidemic disease within local pandemic responses? Particularly a new or emerging disease where there might be little or no direct experience of that disease in country. Bob, that's a very challenging question, but
yeah,
I'd like to have a go at responding.
Yeah, but home-based care is very important because
Fode, stop. This was a question for Bob Okello, but we can come back to you if there's time.
I think that is also a very complex question. Definitely, here what we discovered was like, first of all, leave alone the operational challenges as per the different, economic situation as guided by the World Health Organization in their guidelines. Because looking at the World Health Organization guidelines of the home-based care, the main emphasis was infection prevention and control. But of course, looking at the emphasis of infection prevention and control in their context actually couldn't really mirror well with what the local concept of care is concerned. Because infection prevention and control in the context of the Ugandan villages where I've been working actually is not much emphasized in the case of asymptomatic and the mild cases, which were supposed to be on home-based care. So I think this actually, the implementation challenge basically came, first of all, from the different care imaginaries as proposed in the home-based care for World Health Organization, which was later adopted by the Ugandan government, and then what is on the ground in as far as imagination of care is concerned, coupled with several operational challenges related to housing, related to socioeconomic situation and all that. So it's a very complex question anyway to answer, but I think it revolved around that. Thank you.
Thank you. Thanks, Bob. And actually, when Dr. Sekera was speaking very interestingly about gender and care, I also thought of your interesting findings in that regard. Just in our last 5 minutes, I just wanted us to address two really interesting questions, quite similar that have come in. One from Don Fink, asking this question about how what should community preparedness involve? How can we really sort of support those important needs and responsibilities of communities and connect them to the more conventional approaches? And a related question from Jeff McCaskey really asking also how one can really learn to better reconcile global and local realities. And Zhao, if you don't mind, I'm going to direct that issue to you, because I think it's really one that you've been grappling with in the new WHO unit. Would you have any thoughts, any remarks as to those two issues?
And I'm sorry for the background noise. I think one of the key things is to start thinking about the preparedness phase and risk assessment programs like the STAR program, where we start involving communities from the very early stage of conceiving what are risks, but also more importantly, to conceive mitigation routes, but also the engagement of these communities across the old systems of governance to create trust among all players.
Thank you, and you picking up on that very important element around trust, and such an important one to unpack. Just finally, in our last 2 minutes, there was a question to you, Dr. Zakaria, I think quite an important question right at the beginning, in response to your mentioning that the government of Paraguay had put in place mechanisms and tools to support women in that very important role they were playing in Paraguay, particularly around food insecurity. And one of the audience was asking if you could just briefly detail what kind of measures were taken.
Sí, la idea fue identificar las lideresas de la comunidad, muchas de ellas ya organizadas en grupos, colectivos de mujeres. Mucho el territorio en Paraguay está gestionado también, tiene que ver mucho la iglesia, las parroquias, la iglesia católica tiene como un poder articulador potente, donde también las mujeres son referentes, y esa estructura el Estado tuvo que identificar esos liderazgos y articular con ellos. A veces también, no solamente el Estado, también fundaciones, ONGs, fueron identificando esto en diferentes territorios y el trabajo se articulaba con ellos. ¿Qué instrumentos? Una vez identificados, ¿qué instrumentos? Bueno, para las ollas populares pues era comida, ¿no? Pero en algunos lugares se llegó a más, articulación en cuidados, más allá de alimentos, sino también de cuidados pues, de la comunidad, a tejer ropas, EPP para los hospitales y bueno, este tipo de cosas, a ancianos, a los niños. Bueno, yo creo que el rol de cuidado que tiene la mujer en nuestra sociedad es muy potente y creo que hay que reconocerlo y hay que saber articularlo.
Thank you very much. We just noticed Ahmed Bandi, one of our project researchers, you had your hand up. Did you want to make a brief remark, and then we'll be moving on to session 2. Ahmed, are you there? No, it seems not. Okay, well, thank you very much to project researchers and also to our discussants for wonderful remarks.